Thanks, Dr. Storm. Thanks, Dr. Baker. What a great talk, great session. So it's my pleasure to transition to management of ectopic obstructed upper pole. We have a nice panel set up today for us to go over the treatment options available. And ectopic ureter is defined as a single or duplex ureter that fails to enter at the level of the trigone. Typically, it's an upper pole that will insert anywhere along the path of Gardner's duct. As we remember, that is a Wolffian duct remnant, which the ureteral bud derives. And again, this cartoon depicts the typical course that we'll see anywhere from the very distal bladder neck. This is the more typical course. And when we see these, the patients typically present with incontinence. The focus of today's panel will be on treatment options. And so this is borrowed from Riley Children's Hospital. Thank you, Dr. Rink, for allowing me to use this. But the treatment options are an upper pole heminephrectomy, reimplant, upper to lower ureterostomy, or a common sheath reimplant. The other option that's not on this picture, because this was from 2001, is ureteral clipping that was popularized by the Toronto group. And then last but not least, no intervention. We have a distinguished panel. We'll start this out with Dr. McLeod. He's a clinical assistant professor of urology at Nationwide Children's, and he will give us his approach to upper to lower ureterostomy. This will be followed by Kate Kraft, associate professor of urology at University of Michigan in Ann Arbor. She will give us the upper pole nephroureterectomy in terms of this approach. Moving on to Dr. Van Batavia, assistant professor of urology at CHOP, and he will give an overview and indications for ureteral clipping. And Rosalia Massari, professor and chief of pediatric urology at Raleigh Hospital for Children, will give her indications for ureteral reimplantation. And lastly, Vijay Vimalakanda, from associate professor of urology from Children's Hospital of Colorado, does anything need to be done? And respect to previous talks that have focused around University of Kentucky and Duke basketball, and my wardrobe, I would like to say that I'm trying to keep this in the family and the UNC family specifically with respect to the jacket. And finally, I'll be the moderator, and with respect to when you're, for the last 3 months, you can't leave your house or you can't get a haircut. I'm really looking back at my past history to see if there's any options to decrease the need for hair product. And I found this when I was a youngster and thought this might be a good post-COVID haircut for me. So with that being said, I'd like to present our index patient. This is a 1-month-old female referred for post-natal evaluation of a possible duplex anomaly. Outside hospital, day of life ultrasound revealed possible duplex system on the left, confirmed duplex system on the left. BCUG left, grade 2 reflux. Bladder was normal, no apparent ureterocele. Prenatally, the mother had a history of detection of dilation at 20 weeks. Subsequent prenatal ultrasounds confirmed duplication on the left. Amniotic fluid remained normal, no evidence of bladder outlet obstruction. At delivery, unremarkable female, normal introitus, no evidence of prolapsed ureterocele, and an ultrasound was performed in the office. This is the right kidney. This is the left kidney with dilated ureter going to the upper pole. This is the mid portion of the left ureter, 1.78 centimeters. This is the bladder. So an assessment of 1-month-old with an ectopic duplex kidney, parents elected for watchful waiting and antibiotics. Mom refused any upper tract functional imaging, i.e. MR or nuclear medicine test. So she did well for several years, and she returned now with persistent incontinence despite being toilet trained. Mom acknowledged several non-febrile UTIs, and a VCUG revealed resolution of lower pole reflux. Ultrasound performed. 3 years of age, right kidney remains normal. Left kidney, very good definition of the upper pole. and a dilated left ureter. So the questions will be, what is your recommendation for treatment? And there's a kicker here because this was a twin pregnancy. And so the twin has the identical complaint of persistent leakage despite being toilet trained. This is her ultrasound, 1.62 centimeters dilated upper pole. So my question also is, what would you recommend to the sister? And if you recommend intervention, would you do it on the same day? Good luck and thank you to our panelists. Dr. McLeod, you should.
Can you guys see my screen?
Yep, we can see the screen and we can hear you.
Perfect, thank you. So first of all, thank you for the opportunity to speak on this really esteemed panel on the management of this patient with an ectopic upper pole ureter. And I've been asked to talk about the surgical technique of ureteroureterostomy, which I'll refer to as UU, so I don't jumble my words throughout this talk. So when I was first asked to give this talk, it did make me think of how do we choose or decide what the best treatment option is, and is there a way to really know if we have one? And this brought me to an anecdote from James Lynn, who is a Scottish naval surgeon that I'm pretty sure we all know, who's really been accredited with determining that oranges and lemons were the best approach to prevent and treat scurvy on ships back in the 1700s. Even back in this time, James Lynn understood you really need to have a controlled trial to determine what the best treatment option is, because you need to compare like versus like. And this is really important when talking about the best treatment option, because most of the time our evidence does not reach this threshold. And that is the case in the current situation, where there aren't really any control studies where we can tell you which is the best option. And that brings us to, in a situation where we don't have this level of evidence, how do we tell a family what the best option is? And in my humble opinion, this quote really sums it up. And it really is any technique suitable for the individual patient and the surgeon that gives a good outcome. So bringing us to the case at hand, thinking about the options that all of my esteemed colleagues are going to talk about, I truly do believe that UU is the best option, both in general with the evidence that's available and certainly in my hands. UU was first described in 1928 by Foley in a little bit of a different situation. He was using it to treat an obstructed duplicated system that was infected to reroute the urine around a stone. It wasn't until 1965, then in 1974, that Buchtel and Bellman modified the technique to use it to treat ureteral disease in duplicated systems. Also, as you see here, the number of publications for looking at ureteroureterostomy and pediatric ureteroureterostomy in PubMed has significantly increased over the last few decades and really shot up a lot, especially in pediatrics in the last 10 years. Most of these articles will talk about historical concerns, potential disadvantages, and potential advantages. I'm hoping today that I will show to you that there are more potential advantages than historical concerns and disadvantages. In 1997, Levy hypothesized that a concern with leaving an upper pole dysplastic segment in place is that it could lead to high blood pressure. He had a series of 115 ureteroceal patients that 13 of them, 11%, went on to develop high blood pressure. Interestingly, though, what he found is that it was not the surgical approach used that determined whether the patient developed high blood pressure. An example, it wasn't whether that upper pole segment was left in place or excised. What it was is whether the patient had a history of febrile urinary tract infection or renal scarring, most likely due to the fact that these patients had lower pole reflux at some time, which led to lower pole injury and scarring, which drove the hypertension and not the retained upper pole segment. It has also been discussed in the literature since Buchtel in 1965 that ureteral size discrepancy in yo-yo reflux can be of concern. The thought is that a large ureteral anastomosis from a dilated upper pole to a smaller lower pole segment can cause reflux flow of urine from the upper pole to the lower pole segment up to the lower pole kidney, causing hydronephrosis and eventual injury. However, there's been multiple studies since this time that have refuted this concern, with Huesman studies showing that size discrepancies up to 5 to 6 fold have positive outcomes, Lashley also looked at a very large series of over 100 ureters, found no yo-yo reflux was found. And in the study that we presented many years ago, in 36 patients, we found that you could even taper the large upper pole ureter to accommodate the lower pole so that your ureterostomy didn't have to be very large. And this resulted in no cases of yo-yo reflux. So currently, I think that these major historical concerns don't hold any water, and that we don't need to really discuss those currently, but there certainly are some potential disadvantages that I would also like to discuss. Anytime you do an anastomosis, there's a risk for a stricture or a urine leak. Luckily with UU, the anastomotic leak has been shown in the literature to be anywhere between 0 to 2.7%. Similarly, the anastomotic stricture rate is low, 0 to 2%. One of the main concerns with UU, but also a concern with ureteral clipping and upper pole heminephrectomy, is the distal ureteral stump. Multiple studies have shown that there's a low risk or no risk of any stump infections that may lead to reoperation surgery. However, there was a large series by Lee where 9 of his 80 patients required a second surgery to remove a distal ureteral stump. Lashley also showed that 1 of 18 of their patients required this surgery. Unfortunately, as going back to the need to like compared to like, most of these studies do not do that. And so it's difficult to know when certain surgeons do an upper ureter anastomosis versus a lower ureter anastomosis in the pelvis. Some surgeons leave the distal segment open and some of them tie it off, that it's difficult to determine whether this is truly a concern and how high of a concern it is until we have more standardized measurement and studies. But at current time, it does appear that the risk is still quite low. Lastly, a potential disadvantage doing a UU is that many surgeons like to leave a stent. I personally like to leave a stent. However, in the current age of concern with multiple anesthetics and bringing a child back for another operation, this is significantly a disadvantage. There is emerging evidence, however, where multiple studies have shown that either stentless, tubeless, or stent-on-string options are available, and that can mitigate this concern and have been shown to be successful in both open and robotic assist techniques. So moving on to potential advantages for this technique. The greatest advantage, in my personal opinion, is that there's very low risk to injury to the lower pole kidney. This is in contrast to upper pole heminephrectomy, where series have shown that 5 to 17% of patients experience more than a 5% loss of function. This is likely due to manipulation of the lower pole vascular during the surgical dissection. There has also been a report of a complete loss of lower pole function, which is a catastrophic outcome, as all of you obviously understand. The other main advantage to the UU technique is that the upper pole function is of little consequence, which is extremely important in our case because we don't know what the upper pole function is. In a study that we published on 36 patients, 6 of them had no measurable upper pole function and 10 had less than 15. We found no association with upper pole function in our outcomes, although we did have 1 patient with an anastomotic stricture thought to be due to a significant tortuosity of the ureter and kinking.
30 seconds there.
Thank you.
Yeah.
Kowal recently published on 53 children, also showing that there was no difference in upper versus in function less than 10% or greater than 10% with outcomes. So in conclusion, there are many potential advantages to UU, including minimal risk to the lower pole vasculature. It's amenable to open lap and robot assist techniques, and the upper pole function is of little consequence. And I hope that I've also shown that historical concerns no longer hold water and that these potential advantages outweigh the potential disadvantages. In the case presented, I do believe that I would do a UU on both the child at hand and the sibling, since it does appear that they both have similar anatomy, and I would consider doing it on the same day if I thought the family could handle it. Thank you. And now I'll turn it over to Dr. Kraft.
Thank you.
Sorry, I will try to turn it over to Dr. Kraft.
Yep, up top there's a red right beside sharing. It says stop sharing.
There we go. Stop sharing.
All right, thank you, Dr. McLeod. That was a very convincing argument. And thank you again for inviting me to be part of this panel today. So my charge is to promote heminephrectomy as a treatment option for the management of the ectopic upper pole ureter. And my only disclosure is that I can probably count on one hand the number of times that I've actually performed this operation over the last decade, but I do hope to convince you all that it remains a very viable solution in our armamentarium of management options for this clinical issue. So first, a quick overview of technique for upper pole nephrectomy, since this is really considered by some perhaps the most technically challenging option here. The upper pole ureter is usually quite dilated and can be readily identified at the lower pole of the kidney, where it's separated carefully from the lower pole ureter, divided, and then used as a handle to access the upper pole moiety. The upper pole ureter is then passed beneath the hilar vessels and retracted upward, where then you can see the hilar vessels entering the upper pole, which are individually identified, ligated, and subsequently divided. And usually the parenchyma of the upper pole is clearly identifiable, very distinguishable in that it's a little bit more fibrous, coarse in texture, and you might identify an indentation demarcating the upper pole from the lower pole. The upper pole is then excised with the use of electrocautery, and there are a lot of different energy sources that you can choose. And the lower pole vessels can be clamped temporarily to achieve vascular control. And then after excision of the upper pole, the lower pole defect is approximated using some mattress sutures. You can use a retroperitoneal fat pedicle to help bolster the defect and then close the capsule over the defect as well. And traditionally, the gold standard has been an open approach, so flank incision tends to be the favored option. There are several advantages to upper pole heminephrectomy, which is sometimes referred to as the simple approach because you're cutting something out rather than having to reconstruct. So in situations with a dysplastic, poorly functioning upper pole, you're providing a more definitive treatment option by removing the diseased tissue. And this in turn can help prevent sequelae of renal dysplasia, such as development of hypertension or recurrent pyelonephritis down the road. Upper pole heminephrectomy also offers theoretical advantages over UU, for example, by avoiding distal ureteral dissection, which can be particularly beneficial if there's massive upper pole ureteral dilation. And as such, this approach may be particularly helpful in infants, for example, whose bladders may be too small for lower urinary tract reconstruction, but whose clinical presentation warrants more expedient intervention. Concerns with heminephrectomy include loss of renal function from damage to the lower pole moiety, either through excision of healthy tissue or prolonged vascular compression. Because this approach is an excisional one, it carries with it the higher risk of bleeding, and some argue that given this approach, it's much more technically challenging. And then there's the issue of how to manage continued or new onset lower pole reflux, which many studies suggest is a predictor of need for reoperation on the distal ureter. And with this in mind, either due to reflux, stump infection, or other issues, there may be a need to reoperate distally in the future. With an open approach, if you have to dissect out the distal ureter, then a second incision is often warranted, either a Gibson or a modified Fannin steel. So it's very important when dissecting the upper pole ureter away from the lower pole that the blood supply to the lower pole ureter be carefully preserved. To prevent any complications during dissection, a portion of the upper pole ureter can actually be maintained on the distal portion of the lower pole ureter, and then resection is carried out to the level of the bladder where the upper pole hiatus is subsequently closed. I've talked a lot about the open approach being gold standard, but another surgical option, of course, is minimally invasive surgery, either conventional laparoscopy or a robotic approach. And this can be done either through a transabdominal or retroperitoneal approach. This can also be performed in even small infants. And over time, as we've become more adept at this approach, operative times have decreased. Another advantage to minimally invasive approaches, specifically robotic, is the idea of systemic arterial mapping. My colleague, Dr. McLeod, actually published a nice series looking at the Firefly system and its use in upper pole heminephrectomy to help identify the arterial system. So this is a video that was recently, or a few years ago, put together by Glenn Cannon and Rich Lee, and just nicely demonstrates the robotic approach to heminephrectomy. So in the interest of time, I'm just going to scroll right to the relevant portions here. So we see here the isolation of the very dilated upper pole ureter and its division. Then after transection of the ureter, it's brought behind the hilum. The vessels are then subsequently clipped individually. And then we can see a nice demarcation between the upper pole and the lower pole. And here they've chosen the harmonic scalpel as their energy source for excision. So you can see that this is a really nice approach. Multiple studies have evaluated a minimally invasive approach to upper pole heminephrectomy and suggest that it may offer reduced morbidity with respect to less postoperative pain, earlier discharge home, and presumably a quicker return to work for parents. Other advantages include enhanced visualization, increased magnification, and of course, improved cosmesis, and particularly so with the avoidance of a second incision that's often needed for distal ureterectomy. The literature to date on managing ectopic upper pole ureters is really comprised of small series at single institutions. And when we look at upper pole heminephrectomy compared to UU, we see that outcomes are really quite favorable. And this includes both open and minimally invasive approaches. Bleeding risk is low with reports at 6 to 10% for intraoperative bleeding, postoperative UTI at 5 to 9%. Urinoma is often a concern with potential for entry into the lower pole collecting system, with urine leak and urinoma occurring anywhere from 5 to 29%, most often on the lower end of that spectrum, and with the vast majority successfully managed conservatively. And reoperation on the distal ureteral stump occurs anywhere from about 5 to 14%. As you just recently heard, one of the major concerns that arises with upper pole heminephrectomy is the potential for renal loss. And there have been few series reporting renal outcomes for patients undergoing UU, making comparisons of renal function following upper pole heminephrectomy to UU difficult. However, when we look at recently published series for upper pole heminephrectomy, we see that renal function in general is well preserved. Mean renal function loss in the ipsilateral kidney ranges around 2 to 7%. 6 to 57% of patients are reported to lose more than 5% of their ipsilateral renal function, but again, fortunately on the lower side of that spectrum. And 6 to 25% lose more than 10% of ipsilateral renal function. So when you see that 3-year-old girl in your clinic and her family is wondering what option to go with, one of the best options to consider is an upper pole heminephrectomy. And I would specifically go with a robotic approach for the reasons I've outlined today, because it'll afford her excellent outcomes and she'll be back to her old tricks in no time. And if her sister has the same condition, I agree with Daryl that I'd probably offer the same approach on the same day if the family's willing. Thank you so much.
Thank you, Kate.
Hi, can you guys all hear me? I want to thank the organizers for the opportunity to participate in this panel. It's truly an honor and an intimidating panel actually to be amongst this great group of presenters. I have no financial disclosures. I do have one disclosure, and that is that these techniques were chosen for us. So as Dr. Kraft said, I intend to present a scientific argument for a procedure based on a critical review of the literature. It does not mean that I do this procedure regularly. So Dr. Canning, wherever you are, you can take a deep breath. I haven't gone rogue on you. But that being said, I feel like the initial reaction to ureteral clipping is to immediately dismiss it. And I hope that you'll have an open mind and that maybe by the end of this talk, like me, you will think differently about this technique in specific situations. Interestingly, the original papers in ureteral ligation were in the gynecological literature. In 1912, Dr. J.D. Barney presented 46 cases of unintentional unilateral ureteral injury or ligation during abdominal surgery. Despite being in the pre-antibiotic era, amazingly, only 8 patients required a future nephrectomy, or 17%. 15% of them were for infection. This was followed up by a chapter in this 1921 book, Oxford Surgery, which is available online. In chapter 2 on complications, Dr. John Bland Sutton described an accidental ligation of a ureter in a normally functioning kidney. He writes that the middle-aged woman did well postoperatively, and this led him to express the opinion that it is possible and probable that a ureter has been ligatured in the course of an operation, that the patient has recovered without anyone having a suspicion that such an accident has happened. So in essence, ureteral lip clipping or ligation has probably been going on for decades and patients are doing well. The literature then goes mostly silent until 1979 when Dr. Marina et al. From Mayo Clinic published their first series, the first intentional ligation of a ureter series. This was in patients with advanced pelvic malignancies in which the mass was involving the ureter. Given the palliative nature of the procedure, the authors decided to resect the mass as much as they could with the ureteral segment, leaving the native kidney in place. Despite the majority of these kidneys having normal preoperative functioning, of the 23 patients, the post-op complication rate was kind of high at 65%. The majority of that was due to the terminal cancer nature of the surgery. Only 17% had flank pain, and only 8.7% or 2 had pyelonephrosis, which required a post-ligation nephrectomy. The authors concluded that in their experience, intentional unilateral ureteral ligation was a safe, expeditious, and beneficial. After this paper, the use of intentional ureteral ligation and leaving the native kidney in place spread to the renal transplant field. In 1981, Dr. Schiff Jr. and Leighton from Yale University described 7 patients who had an allograft ureteral necrosis and in whom they performed a salvage secondary ureteropilostomy using the recipient's native ipsilateral ureter and leaving the native kidney in place. They reported no immediate or late postoperative complications, and they concluded that the risk of future problems resulting from ligation of a ureter from an end-stage kidney, which produces negligible amounts of uninfected urine, would seem to be minimal. In what is the largest series to date in the literature, Drs. Galantine and Wright from Texas Transplant Institute in San Antonio in the Journal of Urology in 2002 described 278 patients who underwent native ureteral ligation without nephrectomy. With the mean follow-up of over 3.5 years, they had no cases of infection in the retained native kidney and only 6 patients required a native nephrectomy, all for pain. Here's a table compiling all the data from the other papers in the renal transplant literature. Among all these patients and kidneys, few complications were noted despite decent follow-up, and no patient required a future native nephrectomy. Interestingly, some of these patients were making urine at the time of the ligation, and 11 were actually not even on dialysis yet. Guzman's paper in 2012 was the first to include children where 4 patients were less than 20 years of age. Remember, too, also that all these patients were on immunosuppression and no infections in the native kidney occurred. So now we get back to our patient at hand and her sister. What do we do for this kidney? So much like the Showtime rotisserie that you might remember with the catchy infomercial catchphrase, set it and forget it, can we just clip it and forget it? And instead of Ron Papillo, we have Dr. Armando Lorenzo, whose group from Sick Kids in Toronto has pioneered this technique, and he's a true trailblazer in pediatric urology. I want to personally thank Armando for answering my emails and talking to me on the phone to give me an update of his series, which I'll include here. The first paper from the Toronto group reported outcomes in 9 females with ectopic ureters and incontinence, similar to the patient presented here. They all did well afterwards with no complications. This was followed up by a larger series, which expanded the inclusion criteria, and I'll review that one shortly. And then most recently in 2019, in the Journal of Pediatric Urology, they created a helpful video on the technique for a large ureteroseal. So the technique involves starting with a cystoscopy and a placement of a ureteral catheter in the lower pole normal ureter. This allows for identification of that ureter laparoscopically. Then during the laparoscopic part of the case, the ectopic ureter is dissected at the pelvic brim distally. The isolated ureter is then clipped twice with either Hemolocks or titanium clips, or in the case of a larger ureter or ureteroseal, it can be ligated with an endoloop. In their updated series in the Journal of Urology in 2018, the Toronto group expanded the indications to include ectopic duplex ureters with increasing dilation and large obstructing ureteroseals. They presented 35 consecutive patients with a mean age of just about 5 years and follow-up of almost 2 years. The mean function on pre-surgery DMSA scans was 2.3%, with the most being 12%. Importantly, the median length of stay in these patients was 7.5 hours, with majority of patients going home the same day. In follow-up, 97.2% remained asymptomatic, and 2 patients had infections, although only 1 was in the native kidney, and that led to a pyelonephrosis that required a partial nephrectomy. And this occurred about 2 months post-op after the original surgery. All these patients, though, did have post-op hydronephrosis on repeat renal bladder ultrasounds that remained stable. So adding the Toronto series to that original table with the renal transplant and updating the numbers from Dr. Lorenzo, they had 1 additional complication of flank pain. So that leads to an 8.6% complication rate. This flank pain did require a partial nephrectomy in that patient, leading to 2 patients now with partial nephrectomy for a total of 5.7%. Importantly, they've been following the blood pressures in these patients, and there have been no postoperative hypertension or any other complications. So now if we add the transplant or pediatric urology literature together, which I know is not fair, but we get a total of 404 kidneys that have undergone ureteral ligation with native kidney remaining in situ. Of this group, only 3.5% have had complications. The majority do probably have hydronephrosis post-op. Importantly, though, native kidney required removal in only 2% of patients. So given the potential for complications, especially in a minimally functioning kidney and the high incidence of post-op hydronephrosis, Sharifi et al. And his colleagues from Tehran, Iran, published a paper in the Journal of Pediatric Urology in 2017 that described a modification of ureteral clipping wherein the upper ureter, the upper pole vasculature is also ligated at the time of laparoscopy. They noted an operative time of only 48 minutes, and they noted the patient did not have hydronephrosis or any complications afterwards. So overall, the literature seems to suggest that ureteral ligation or clipping results in shorter operative times and anesthesia times, can potentially be a day surgery, has a minimal risk of infection in the retained kidney, especially if there's no history of UTI. The procedure also has minimal risk to the lower pole moiety, which may occur with the other techniques presented today. I would also argue that the complication rate of ureteral clipping is equal to or less than the rates from the other procedures that have been presented. And lastly, the technique does not burn your bridges. So even if there is the rare case of a complication, you can still perform a UU or a heminephrectomy later. As with any invasive procedure, patient selection is critical. So the ideal patient for clipping is probably one with a non-functioning moiety or minimally functioning moiety, no history of urinary tract infections, no reflux into the distal stump. Ectopic ureter is ideal, and then a non-functioning large ureter should also be considered. There are still some unanswered questions, such as what is the minimal cutoff for function for clipping?
Time, Jason.
Long-term
Yep.
Oh, sorry. So then maybe we should just clip it and follow it. Thank you.
Great job, Jason.
Well, good afternoon. And as the old person on this panel, I can say that I've done everything except the ureteral clipping that Dr. Van Batavia has promoted here. So we have an interesting problem here. This little girl is 3 years old. She's awfully cute. Now Tony added her sister to the mix. Certainly, if you can get both kids done on the same day, it's good. If you have private rooms, it poses a problem for the parents. But in the COVID days, both parents can be in the hospital. So I guess it's helpful if there are two parents who want to come. So I imagine this is what her MRI would look like if she had one. On the ultrasound that Tony showed us, it looked like there was a fairly good cap of parenchyma there. So my goals for therapy, having done all of these, are always the same. We want to avoid UTIs going forward. We want to optimize continence. We want to avoid secondary surgeries. And we also have to pay attention to cosmesis. And this is regardless of the child's gender. Now, my concern always is that if you have multiple approaches to a problem, is there a gold standard? So I'm going back to the term gold standard. And what determines the preferred approach is that the upper pole function, is that there is reflux to the lower pole or the contralateral side. And really, surgeon's preference, I think, is really something that we have to take into account. And over time, has surgeon preference changed? So in 2010, Paul Magurian published a series where they saw that 60% of respondents preferred an upper pole heminephrectomy. Now, the other thing with children with ectopic ureters, a lot of the data really is based on data that refers to kids with ureteroceles. So you can see even in the same institution, things have changed. So Toronto first promoted upper pole heminephrectomy, and 40 years later promotes ureteral clipping. But I'm going to talk about ureteral reimplants. So if there's lower pole reflux or contralateral reflux, to me, it's a no-brainer. You have to be down in the bladder anyway. May as well get everything done the same way. If it's a problem with incontinence or obstruction, then that may require some thought, and some of the other choices may be better choices, particularly if that's what you're comfortable with. Certainly, it takes care of the pathology at hand. You avoid a flank incision. A visible scar is avoided. This is a familiar surgery for many of us. The injury to the lower pole is avoided, and we've heard reports of lower pole loss of function. It could potentially improve the function of the upper pole, removing the obstruction, and there's no need for a robot. So while many of us on this panel today have robots available, there are many people who don't have robots available. Probably the most comprehensive paper to look at the non-functioning upper pole and surgery on the lower pole was multi-institutional. And they did a really nice job looking at the pros and cons of upper pole surgery and lower tract reconstruction. And one of the concerns was that the dilated non-functioning upper pole could be maintained. However, in their study, they noticed that there were no issues with the non-functioning upper pole. And this was seen over and over again by the group in Buffalo, by our group at Riley. And then the other issue that came up was that of urinary tract infections with ureteral stumps. If you look here, you can see a stump of a ureter. It's quite big and dilated. And the possible sequelae of these are that you can have recurrent urinary tract infections and leakage. And we see that the residual stump is a problem in up to 12% of other surgeries. What prompted me to really embrace the lower pole model is simply a case of a girl who presented to me, actually a young woman who's 21 years old. She had a right upper pole heminephrectomy at 10 months of age. She subsequently underwent a distal ureterectomy at the time of left reimplant. For the next 12 years, had recurrent UTIs and incontinence. Attempts were made to fulgurate this upper pole stump and to deflux it in order to avoid reflux into the stump and these potential infections. This was repeated again. She presented 6 years later, again, having had multiple recurrent urinary tract infections and incontinence, and finally had transvaginal excision of the distal ureteral stump. The pain and suffering that this girl had related to the stump were quite amazing. It really had altered her life. And whether or not this could have been avoided by a lower tract surgery, I'm not sure and I can't tell, but having removed this stump certainly made a lot of difference, and she's been infection-free for the past year since her surgery. Does lower tract surgery potentially have problems? Certainly it does. It may damage the urethral control mechanisms, especially when you're operating on small infants. It may be very difficult to get to that very distal ureteral stump, but we don't have any data to support this. So I think that for those of us who are comfortable operating at the lower urinary tract, it certainly offers an excellent treatment option. And I would strongly encourage people to consider this as a treatment option. And I hope everyone has a nice summer. I'm sure a lot of us won't be able to go away, but it's been a pleasure to be on this panel.
So thank you guys. I am here to sort of clean up and talk about the last potential option. For some reason, I didn't get my first slide up, but I'm here to talk about non-operative management. I also have no disclosures except to say that I have certainly been accused of being a non-operative surgeon in my past, so this probably was the right topic for me to pick. Like others have discussed, I think the goals of treatment in this case are really to minimize the risk of febrile UTI and morbidity, to preserve the function, if possible, in the upper pole, and minimize the risk of loss of function to the lower pole moiety. And finally, as our field continues to move towards minimally invasive approaches to minimize surgical morbidity and to be cognizant of the potential risks of anesthetic exposure in the first few years of life and minimize those potential neurocognitive impacts as well. As our panel has discussed, there are 4 major surgical options to consider, and to that I would add the 5th option that our adult colleagues also discussed, which is active surveillance or non-operative management. And I think that there are many things that our panelists have discussed that are positive about these surgical approaches. My goal on this panel is to discuss all the negatives of these approaches that they've discussed. Dr. Kraft did a great job talking about the potential definitive management of the dysplastic upper pole. However, there are also several significant risks with this, including the risk of urine leak, either partial injury or potential complete loss of the lower pole moiety in rare cases, the risks of infection potentially from the retained ureteral stump, and case series have suggested upwards of a 10% risk of reoperation in these cases. Finally, the potential benefit of removing the dysplastic upper pole appear controversial, as previously discussed in the paper by Levy et al. In 1997. When we look at ureteral reimplantation, which is sort of the more definitive lower tract reconstructive approach that Dr. Mazzari so eloquently discussed just a moment ago, we think about the fact that this avoids those injuries to the upper pole or the lower pole moiety. But I would say that there are also significant risks. The anesthetic time of a ureteral reimplant surgery can be fairly significant. Oftentimes, these ureters are significantly dilated, requiring tailoring, which may lead to an increased risk of leakage with subsequent ureteral stricture, and a potential increased risk of visco-ureteral reflux. And finally, there have been conflicting data on whether or not early common sheath reimplant in these patients could be associated with bladder dysfunction. Moving on to ureteroureterostomy, there definitely are benefits to this approach in that it does seem to have lower surgical morbidity, shorter anesthetic times, and again, avoids the injuries to the lower pole. But again, there have been reports of urinary leak, stricture at the anastomosis, either de novo or persistent reflux, which especially is of concern in the case where the patient had lower pole reflux to begin with, potential risks of the ureteral stump, and finally, again, a potential risk of anywhere from 3 to 10% for reoperation. And finally, Dr. Van Batavia took the least invasive approach, adapting from the transplant literature the option of ureteral clipping, either with or without vascular clipping. But again, there are significant risks looking at this. The series from Toronto suggested potential risk of UTI and pyelonephrosis that might require subsequent partial nephrectomy. And again, they're really the only group that has published data on this approach, leading to limited sort of ability of us to really understand what the long-term outcomes and potential sequelae might be. So I would argue that really the natural evolution of our field from open surgery to minimally invasive techniques is to choose the least invasive technique or non-operative management. And this has really been proven to be an effective modality in the ureteroseal literature. There have been several case series looking at ureteroseals and non-operative management, and in well-selected patients, primarily those with poorly functioning or non-functioning upper pole moieties, an absence of a history of febrile UTIs, as we see in this case, and an absence of lower pole or bladder outlet obstruction, observation appears to be both safe and effective, with less than a third of patients in these series developing febrile UTIs, and even fewer ultimately requiring a surgical approach. And so I would say, I think it would be perfectly reasonable to watch in this case. This is a patient that has really minimal upper pole function, and as a result, observing provides minimal risk of loss of renal function in this patient. We know from primary obstructive megaureter that antibiotic prophylaxis is an effective way to reduce the risk of UTI and dilated moieties, and may be an option to try to prolong the time to surgery. And observing would provide a way to minimize the anesthetic risks, especially in infants less than 3. And again, just as Dr. Van Batavia mentioned, by not manipulating the upper pole or doing a lower tract reconstruction, you always have the option to intervene later if patients develop symptoms. So in this case of the twin girls, I would say if it's clear that the incontinence is from the upper pole and moiety and they're both over the age of 3, then certainly consider operating. But if this is really a situation where these patients may have underlying dysfunctional voiding and the likelihood of having a true adverse outcome because of the persistent upper pole moiety is less clear, observation isn't a bad approach. And to prove that the proof is in the pudding, this is actually a patient of mine who at 3 months had an obstructed ectopic upper pole ureter. At age 3 is her ultrasound showing complete involution of that upper pole moiety. She's now 5 and has had no subsequent issues. So I think that in the appropriate selected patients, doing nothing is really an appropriate and a thoughtful approach to take. With that, I'd like to turn this back over to Dr. Herndon for our discussion. Thank you so much.
Thank you for all the esteemed panelists. At this point, we'll go to our Q&A. And on the phone, I'm going to show you, hit ask if you have ask a question. Using the chat, the panelists, we can't see that. We're in a different space. So again, on the streammeeting.com, hit ask and ask your question, and I'll read it off. So first question, is there any role of lower track approach or TUU in case of presence of controlled hypertension on medication with low upper moiety function? So the upper pole doesn't work. Is there a role for low urinary tract approach or TUU in that situation when they're controlling the hypertension with medication? So I'll send that to Rosalia.
Well, I think the first thing is really to be sure what is contributing to the hypertension. You know, is the child hypertensive for other reasons, or is the child hypertensive for the reasons of having a dysplastic or poorly functioning upper pole? I think that's a difficult question to answer. I think the help of the nephrologist is really important in those cases. Those are the important questions to have answered before you embark on the surgical journey.
I think personally, here at VCU, we really have a good peds nephrology relationship. So we actually have a couple of kids coming up with large cystic ectopic ureters that have hypertension that the peds nephrology team feels would be warranted with upper pole heminephrectomy. And so that's where I think, with respect to that question, I wouldn't go out on an island, when we have the medical kidney doctors that can get involved. All right, that's any more questions from our group here? So I'll go ahead. Daryl, I got a question for you with respect to the approach. Certainly, you can make an inguinal incision and get to the both ureters pretty easily. But I would say, if you look at the trend, and I would be guilty of this, a lot of us are using robotics because I think it facilitates robotics in other spaces. And so I wonder if you could comment on what you do a lot of laparoscopy there at Nationwide. What's your preferred approach? And certainly you would do whatever the patient would like. But
yes, Dr. Jayanthi, who trained me as well, he does a high UU with a laparoscopic approach. Personally, doing robotic approach is my preference, and hopefully Patricio is listening somewhere. I have started doing my UUs robotically with a Hydes approach. I find that I can still get pretty low down in the pelvis. I just see where there's a good window that I can find the two ureters as low as possible. You certainly do have some, it's a very tight space, especially in little children. But even with a Hydes approach, I find that you are able to get access to the ureter and to do a successful UU and avoid any visible scars, as Patricio has shown.
And that would be in a child that's presenting with incontinence, a little bit older, not a not a 6-month-old or something.
Yeah,
like
typically
that
that would be an older child. The open approach, I mean, as everyone knows, is a great approach as well for the really small children, that you don't have the luxury of waiting for them to get a little bit larger. Yes.
Yeah. So then the next question was, let's pretend this was a ureterostomy, same setup. If you just punctured, would you guys do anything differently? If there's no reflux, you do a puncture. Would you just let that be? And again, without infection and those sorts of things.
I can take that one, Tony.
Yeah.
I would say absolutely. I'd be very conservative if the patient was doing well. BCG was negative after ureter puncture. I have several patients in my practice that look like that, and they've done beautifully. So I think less is more. I would go along with BJ in that situation.
That's great. So any other questions you guys can ask each other as well. I don't want to. So I've got a question for you, Jason. And this is one of the, I guess in the back of my mind, issues with ureteral clipping. You know, when we manage some of these patients, we manage them, you know, with a 1 month or 6 month lens. But when you're doing ureteral clipping, and then let's say they're 85 years old in a nursing home and have a UTI, and no one really knows they have an obstructed now upper pole, it seems like the follow-up needs to be pretty long before we can convincingly adopt this approach, if you follow me.
Yeah, no, I think one, the patient who did a pyelonephrosis did develop early, about 2 months, it seemed like postoperatively. Yeah. And again, the renal transplant literature is very interesting in the fact that they were immunosuppressed and no infections in that literature. Again, I don't know if they have any longer term follow-ups or if they had any indication or any complications later. I do think that, if I were doing this, you might want to think about some prophylactic antibiotics early on. But again, I don't know the time period that you'd want. Dr. Lorenzo did mention that if there's a history of UTI, he's very resistant, at least now, to doing the procedure. Possibly, you'd have to think about it really hard. But if there is no infection history, in the other procedures we're talking about too, a lot of them you are leaving a distal stump and other things that I think require follow-up long-term as well. So one would argue that the follow-up for all of these probably is going to be lifelong, even in a UU, to see if there's dilation or any effect on that kidney.
And now some questions are rolling in here. With respect to doing the robotic approach at the UU, at what level do you do it? At the vessels, or when you mentioned the Hyde's approach, obviously it's pretty low, or I guess it could be going the other direction.
Yeah. I personally do it quite low. It really depends on when I look in where I see a good area. I often will try to go transmesenteric. So a lot of times you look in and it'll just kind of show you, and it typically is down by the vessels. But I don't.
So you're not looking towards the head when you're doing the Hyde. You're not looking up.
I'm looking down. Yeah, typically looking down. Yes. Okay,
that's a good question. And with ureteral clipping, there's a question, and again, this would be historical, I guess, Jason. Does Armando advocate aspirating out the urine and then clip? It showed that he clips, and I imagine that's so you don't have a leak, right?
So it depends on how dilated the ureter is at the time.
Okay.
If it's a decompressed system, he would just clip it, 2 clips. If it's a larger ureter, or for ureterostomy especially, which I think is an option as well with the ureterostomy, he does cut into it about halfway, then aspirates upper and lower to decompress it, and then we'll put the endo loops on.
Okay. BJ, I have a question. When we do all these active surveillance, the other piece of that is following patients that, let's say, I would have to confess that early in my career, I did a lot of upper pole heminephrectomies, mainly to rid the problem. So then potentially, if you've dealt with everything but the ectopic stump, then you really don't need a lot of follow-up after you assure that the lower pole is viable and there's no urinoma. Could you speak to that or comment to that?
Yeah, so for me, I tend to watch reasonably closely the first year of life, about every 3 months, and then I slowly space out the follow-up. That being said, we have a I think Nationwide also does, we have a pretty strong K-cut program at our institution. So we do recommend, regardless of the surgical approach, and kids who have significant unilateral or bilateral disease, that they're followed at least annually with a blood pressure and a urine for microalbuminuria, because the nephrology data actually suggests that some of those patients may have sort of occult or renal insufficiency or renal injury that we don't know about. So to me, the approach doesn't necessarily change my observational or sort of management post-op or in follow-up. But I do think it doesn't have to be every 6 weeks for the rest of a child's life or anything like that.
And the SFU registry that we've recently submitted some data for this would show that for those kids, they're at much higher risk of infection, and prophylaxis may be indicated. Are you prophylaxing that group, and for how long?
So I try to utilize or apply the literature from the primary obstructive mega-ureter group. So I tend to prophylax those kids somewhere till around 18 to 24 months of life.
Okay.
With the thought being that the ureter is decreasing in size, you could stop that earlier.
Great. Rosalie, I was going to ask you a question with respect to when you're doing the reimplantation. You mentioned the patient that you experienced. You think these are kids that have, some of the kids I encounter have a large cystic component when they insert in the Gardner's duct. And I think those are probably the kids that I would tend to favor to do lower tract reconstruction as opposed to an upper tract. Does that factor into your approach?
It certainly does, because I think those are the kids that are going to be at greatest risk for either having obstruction of that segment and essentially what I think of as an abscess going forward, or refluxing into that little stump and having a leakage of urine. And oftentimes that urine that leaks out is pretty foul. So, so I do take that into consideration and try to work, outside of the bladder as far as I can, do cystoscopy up front so I know what the distal extent is, hopefully being able to find that ectopic ureter.
And when you do that, some have described this, do you split the trigone to go all the way down to get that ectopic stump, or do it laparoscopically, or what's your preferred approach?
Try to avoid splitting the trigone, but if you have to get it down all the way, yes. Always keeping in mind continence, making sure that you're not getting overly aggressive and destroying the continence.
Sure. And again, I'm waiting for questions, so I'm just going to take the liberty to ask some. With respect to the upper pole heminephrectomy, I've been using the vessel sealer and been a little bit more liberal with it and not clipping, because it does say 8 millimeters, which is pretty darn big vessel. And those upper pole vessels really don't get that large. Have you tried that? It really does make it a lot easier to just dissect that plane without having to isolate every vessel and clip it and then deal with the clip.
Yeah, so again, my full disclosure, I don't do this operation often, but when I do, I really favor the ligature. It's similar concept.
Yeah, that's right. Mm-hmm.
Yeah. So, and I think it works great. I think 7 millimeters and under is the limit for that device, and I think it works great.
Great. Okay, guys, we're running on our last minute. I wanted to thank everyone for the great presentations and the preparation, and thank Doug for inviting me to moderate this panel. And I'm going to go cut my hair at this point. So, in any event, you guys have a wonderful remaining portion of the meeting, and congratulations, Louis and Emily, on a great meeting. At this point, we're going to transition over to Dr. Caldamone, who's going to moderate his session on using pyeloplasty as outcome for UPJ studies.